Hi, my name is Connie Luklanis and you're watching the video Alphabet Patterns Management. In this video, we'll be discussing the management of patients who've been diagnosed with an alphabet pattern, and we will again be specifically concentrating on A and V patterns. Okay, so in reality, most alphabet patterns do not require treatment. So where you have a small A and V pattern, in most instances, patients remain asymptomatic and they are cosmetically acceptable, in which case they're left alone. So the determinants which will guide you as to whether to manage the patient for their AV pattern is firstly if the patient is symptomatic. Now we can go down the road of conservative management or surgical intervention. Often patients will require surgical intervention when the patient is symptomatic, there's poor cosmesis, or the patient requires an uncomfortable abnormal head posture to achieve BSV. In terms of conservative management, if the cosmesis is reasonable, it may be appropriate to try and manage symptoms without surgical intervention. Now, the aim of management is to achieve comfortable BSV. Now, where there is a patient with an uncomfortable abnormal head posture or the cosmesis is poor, generally you're going to need to move into surgical management. But if the patient has the potential for BSV, the operation should actually provide the patient with comfortable BSV as well. Now, when considering the management of AV patterns, the other thing we need to take into account is where is the most problematic position of gaze. So if we look at the child over to the right here as an example, we can see that in prime position the patient has an esotropia in primary, patient has a esotropia in up gaze, and in down gaze there is relative alignment. So in this particular instance, the positions that are most problematic are primary and up gaze. Now, say you have a patient who has only diplopia in up gaze. Now, this is a position that we don't utilise as much as down gaze. Down gaze is extremely necessary in various day-to-day activities. Where the issue is in up gaze, we might opt to try for conservative managements, which is moving your head, for instance, rather than your eyes, rather than having surgical intervention. Of course, if the cosmesis is very poor in up gaze, one might consider going down the road of surgical management in these instances. Also, another consideration is to consider the height of the patient. And in particular, this comes or applies to children. Now, children obviously are quite short and they're looking up all the time. So if their issue is in up gaze, it will be very noticeable during their childhood. However, keep in mind that as that child becomes older, they're not going to be looking in up gaze as frequently. So sometimes we'll wait and watch a particular patient and manage them conservatively if they need to be managed at all, and consider intervention when they're taller and older. Now, in terms of non-surgical management of patients with AV patterns, well, firstly, we can assist a patient to utilise an abnormal head posture, either a chin up or chin down, dependent on what sort of AV pattern they have. If the abnormal head posture that's adopted is uncosmetic and relatively large, then really you would need to move to surgical intervention. You could consider prisms if surgical intervention, for instance, is contraindicated, and it's kind of difficult to utilise because of the incompetency of the deviation. You're looking at a strabismus that changes dependent on gaze, whether up, down or primary. You could consider a sector prism, so you put a prism up in the top part of the glasses, for instance, if the patient has an issue in up gaze. And of course, you can also consider occlusion for diplopia and sector occlusion, where you're looking at trying to alleviate diplopia in one of the positions of gaze. Just note that once you're really starting to consider grounding prisms in glasses or sector occlusion, the patient must be having symptoms that they're not able to deal with and that they need alleviation from. And in these instances, you're probably going to need to go to surgery rather than to leave the patient with non-surgical management. If the cause of the AV pattern is a neurogenic palsy, clearly you'll be waiting that 6-month period or more to see if there is an improvement in the neurogenic palsy and also consequently the AV pattern. However, should you have, as an example, a patient with a concomitant strabismus with a primary isolated inferior oblique overaction, they generally don't improve over time, so your consideration will need to be surgical at some point if you're looking at managing the patient conservatively, which means that they're having symptoms from their alphabet pattern. So moving on to surgical management, there are several operations that can be performed to manage a patient's AV pattern. So surgery can be performed on the oblique muscles, on the horizontal rectus muscles, on the vertical rectus muscles, and also surgery can be done on pulleys. Let's go through each of these. Okay, so firstly with oblique muscles, we can either weaken or strengthen them. Now last semester, we only really learnt about the recession of an extraocular muscle and the resection of the extraocular muscle. Now we're going to start learning about various other procedures that are utilised in managing patients, and this is because we're now working with vertical muscles, and vertical muscles we tend to have a lot more procedures we can perform on these extraocular muscles. So in terms of weakening procedures, the inferior oblique you could recess, however a myectomy could also be performed on this particular muscle. And a myectomy is where there is a part of the muscle that's removed in order to weaken it. The superior oblique can have a tenotomy or a tenectomy can be performed on the superior oblique. In these particular instances, the tenotomy is where the tendon is divided and as such is weakened. And the tenectomy is the removal of a part of the tendon, again, in an attempt to weaken it. We can also anterior position the inferior oblique or the superior oblique to weaken it, in which case what you're doing is you're essentially transposing that oblique muscle anteriorly. In terms of strengthening procedures, here I've only given you superior oblique strengthening positions because generally inferior obliques are not strengthened in AV patterns. So we have a superior oblique tuck and a superior oblique Harada Ito transposition. We'll talk more about these when we move to fourth nerve palsies, as they're more relevant in that particular instance. Now in relation to the inferior oblique myectomy and the superior oblique tenotomy, I've provided you with some links to videos of these procedures via Alamet. So have a look at these videos so that you can gain a better understanding of oblique muscle surgery. Now you'll recall earlier in the video on etiology of AV patterns that we discussed that the most common cause for a AV pattern is a overaction or an underaction of a cyclovertical muscle. So in terms of the focus here on oblique muscle surgery, what I've provided you beneath is a summary of, again, what over and underactions of the obliques we require to see a V pattern or an A pattern. And in this table, we have an overview of the obliques that you would strengthen or weaken in order to correct an AV pattern. Let's take, for example, a V-ESO. Now here is the V, and what we expect from a V-ESO is generally an overaction of the inferior oblique. It's an abductor, and therefore what we'll see is, in the V-ESO, a reduction in the esotropia in upgaze. On the other hand, we have the superior oblique here, which is a minus, it's underacting, in which instance we would have a reduction in abduction in downgaze, and in this instance we'll get an increase in the ESO. So as expected, what you would find is that you would want to weaken the overacting muscle, the inferior oblique, and strengthen the superior oblique. You could also look at anterior positioning the inferior oblique, which is actually a weakening procedure. We can also perform surgery on the vertical rectus muscles to correct for an AV pattern. Now, this is a less preferred surgical option as compared to, for instance, oblique muscle surgery, or in a moment we'll see horizontal muscle surgery. Now, in terms of what type of procedure is performed on these vertical rectus muscles, well, we generally don't recess or resect these muscles for the purposes of correcting an AV pattern. What is done instead is a transposition of the vertical rectus muscle, either laterally or medially, in order to weaken or strengthen that extraocular muscle. So as an example, if you take the inferior rectus and you move it medially, what you will end up doing is strengthening the adducting action of the inferior rectus in down gaze. Okay, so here we have an overview of what we've just discussed, and the table represents the procedures that would be effective in A or V patterns. And again, I've given you a reminder below here, this time focusing on the rectus muscles, on what over and under actions we would expect of the rectus or the vertical rectus muscles to cause an A or V pattern. So let's take an example of an A-ESO here. Here we have the A, and we're expecting a superior rectus overaction or an inferior rectus underaction. And in terms of weakening the superior rectus, what we need to do is move the superior rectus laterally in order to weaken its effect and thereby have an impact on improving the A pattern. Now, in the instance of the A-ESO, we're only considering the superior rectus and moving it laterally because with the A-ESO, it's the esotropia getting worse in up gaze and the superior rectus is an elevator. So we want to have most effect in elevation. So we'll go for the superior rectus rather than the inferior rectus transposition. Okay, let's move on to horizontal muscle surgery. So we actually can perform horizontal muscle surgery to improve AV patterns. Now, you'll recall on the video regarding the etiology of AV patterns that the displacement of horizontal muscles will cause an AV pattern. So clearly we can manipulate the position of the horizontal rectus muscles so that we can correct an AV pattern. And generally, the upward or downward transposition of the horizontal muscles can be combined with a recession or resection. So say, for instance, you have a large esotropia in primary position and you're performing an operation to correct the esotropia. Well, at the time of the procedure that you're performing the weakening or strengthening procedure on the rectus or the horizontal rectus muscles, you can also proceed to transposing them upwards or downwards. So often it's done in combination. They're just not moved up or down. Often you're trying to improve an ESO or an exo in primary, and in addition to this, the surgeon adds the transposition of those particular muscles. Now, the rule of thumb is that the vertical transposition of the rectus muscle weakens its horizontal action in that direction. So if you move the medial rectus, for instance, upwards, you will weaken its action upwards. Okay, so you will weaken adduction in elevation. So generally what will happen is that a recessed muscle, so a horizontal muscle that you're weakening, will also be shifted in the direction of maximum deviation, and a resected muscle, so one that you're strengthening, will be shifted in the direction of least deviation. Let's look at an example to make more sense of this. Let's say we have an A-ESO. Now, in the A-ESO, it becomes worse, or the esotropia is becoming worse in up gaze. Now, in order to deal with the ESO, we will weaken the medial rectus. Okay, so we'll recess the medial rectus, and the rule is that the recessed muscle is going to be shifted in the direction of maximum deviation. So with the A-ESO, the ESO is becoming worse in up gaze, so we'll transpose that medial rectus upwards along with weakening it. And on the other side, if we're resecting the lateral rectus, the ipsilateral lateral rectus, then we'll transpose that downwards as well as strengthening it. So here we have a diagrammatic representation of what we've just discussed, and this helps remember how to transpose the horizontal rectus muscles for the purposes of correcting an AV pattern. So what we see here is that in image A we have a V pattern, and for V patterns the medial recti are displaced down or transposed down, whilst the lateral recti are transposed up. And remember that the recessed muscle is being moved in the direction of maximum deviation. So let's take a V-ESO for example. In a V-ESO, the esotropia is becoming worse in down gaze. The recessed muscle is the medial rectus, and this is being displaced downwards towards the maximum deviation. Let's take the example of a V-EXO. In a V-EXO, the exo is becoming larger in up gaze. The recessed muscles are the lateral recti, or the lateral recti will be recessed, in which case it will be transposed upwards in this particular instance. Okay, on the other side we have an A pattern, and this indicates that medial recti are transposed upwards, whilst the lateral recti are transposed downwards. Now this table provides an overview of what we've just discussed in the diagram and in the previous slides. The only thing to add here is that the surgery can be bilateral or can be unilateral. So say for instance you're dealing with a V-EXO and you're performing bilateral lateral rectus recessions, you can transpose those lateral recti, and in that instance you are doing bilateral surgery. However, where you're doing unilateral asymmetrical surgery, so you're doing a recess resect on one eye, again you can transpose those particular extraocular muscles. So depending on what procedure you're doing for the primary deviation ESO-EXO, you can elect to do bilateral or unilateral surgery in terms of the transposition of the horizontal extraocular muscles. I just want to bring your attention to the fact that if the surgeon doesn't transpose the medial lateral rectus, they also have the option of slanting the extraocular muscle. Now what this means is that when, for instance, they recess a muscle, and let's take the example of the medial rectus, what they can do is recess the muscle by a different amount at the lower margin as compared to the upper margin. So if the surgeon recesses the medial rectus more posteriorly, or recesses it more on the lower margin as compared to the upper margin, what will happen is that the muscle will have a weaker action as it looks into down gaze. So in that instance, it will have a better effect, or you'll weaken A deduction as the patient looks down. Okay, so just remember that this is also an option whereby the surgeons can slant the muscle insertions in order to have an impact on the AV pattern. Now, where appropriate, pulley surgery can also be considered. Now, this would be done in instances where there is an anomaly in the position of the pulley. So in patients with mongoloid or anti-mongoloid features where pulley displacement may have occurred, or in patients with craniofacial disorders where sometimes there are pulley displacements, you would consider repositioning the pulley in these instances. Now, I've brought back the images from the etiology video where we can see here that generally with A patterns there'll be an upward displacement of the lateral rectus and a downward displacement of the medial rectus, and with V patterns it'll be either a combination of a downward displacement of the lateral rectus and upward displacement of the medial rectus. So in terms of repositioning the pulleys, this table describes what would be done to the pulleys in order to correct for the AV pattern. So in relation to an A pattern, we can see here that if the lateral rectus or the lateral rectus pulley is displaced upwards, we'll move that down, or if the medial rectus is displaced downwards, we'll move that up, etc. Okay, so how does the surgeon decide as to what procedure to perform, given that we have a plethora of options in relation to correcting the AV patterns? Well, firstly, the primary surgery that will be performed, if appropriate, is correction of any oblique over actions. So what we're going to be looking for is there a presence of an oblique overaction? And if there is, that will be dealt with in order to manage the AV pattern. Now, in correcting the oblique overaction, if there is a significant ESO or exo deviation in primary position, any weakening of the obliques is not going to have a significant impact on an ESO or exo that's large in primary position. So you can actually combine surgeries whereby what you'll be doing is operating on the horizontal muscles and the oblique muscle. So here now we have the scenario where there's a V pattern and there's a distinct inferior oblique overaction. And so what we would do in this instance is weaken the inferior oblique and then consider if there is a horizontal deviation that also needs to be managed, in which case a recess resect would be performed depending on what procedure is required. I've also just added an exception here where in patients who have bilateral fourth nerves, a procedure will be done likely on the superior obliques because of the significant torsion that the patient is experiencing. This will make more sense once we do fourth nerve palsies. Now let's look at the scenario where we actually have a V pattern but there is no inferior oblique overaction. So this is the instance where if the horizontal muscles are being operated on in order for an ESO or an exo to be corrected, we would look at transposing these muscles up or down to correct for the AV pattern. You could actually do it even if you weren't doing a recess resect for primary, but if you are, it becomes more convenient to transpose as well at the same time. Okay, so there's two options here. Depending on what procedure is being done for any primary position deviation, it'll either be bilateral or unilateral. Now moving on to superior oblique overactions. Now in this instance again, if you have an oblique overaction, you correct this first in an attempt to address the AV pattern. So a weakening procedure of the superior oblique will be performed, such as the tenectomy or tenotomy of the superior oblique. Okay, if however there is a significant ESO-exo deviation in primary, a recess resect procedure could be performed on the horizontal muscles also to address the ESO-exo in primary. So what if we don't have a superior oblique overaction? Well, just as before, we'll do a vertical transposition of the horizontal rectus muscles. Again, we can do bilateral surgery or unilateral surgery dependent on what procedure we're doing in primary position for an ESO or exo. The selection will be made based on that. If there's no procedure being done for an ESO and it's just a transposition, the surgeon will decide what their preference is as to bilateral or unilateral. Now here we have a flow chart of some of the most common procedures performed for the correction of AV patterns. And again, what we see here is that the first consideration is there an oblique overaction or is there no oblique overaction? So where there is an oblique overaction, then for a V pattern we're weakening the inferior oblique, and for the A pattern we're weakening the superior oblique. Where there is no oblique overaction, then for both the V pattern and the A pattern, the consideration or the first consideration is to look at the displacement or the transposition of the horizontal muscles either upwards or downwards depending on whether it's a V or an A pattern. And the other consideration is whether there is an associated underlying strabismus. So as an example, if you have a patient with a intermittent divergence XSXT with inferior oblique overactions and a large V pattern, you need to deal both with the exotropia. So you may perform, as an example, bilateral lateral rectus recessions, and at the same time then also consider the AV pattern or the V pattern in this instance and address the inferior oblique overactions as well during surgical intervention. So in summary, non-surgical management of patients with AV patterns can be given for patients who have a relatively small AV pattern and who have relatively mild symptoms. Now, most patients with AV patterns will be relatively small and won't require any intervention, conservative or surgical. However, once the patient starts having a cosmetic issue in relation to the AAV pattern or are quite symptomatic, then our only real option is surgical intervention. So the first thing we want to consider is there any oblique overactions, and this will be targeted as the first choice treatment. Then, if there's no oblique overaction, we can start looking at transposing the horizontal extraocular muscles. We also have the option of transposing vertical rectus muscles if required. And lastly, repositioning of the muscle pulleys is also possible for patients who've been diagnosed with a displacement of their muscle pulleys. Okay, that brings us to the conclusion of this video. Thank you for watching.